Yeah, I think it's 5:10. I hope audio is very clear. So on behalf of NNF Karnataka chapter, we would like to welcome all again. And we are extremely sorry for yesterday's issue, which was out of our control because the entire Zoom had an issue yesterday. So we are able to resolve it by contacting them. So now things are fine, I hope. So without wasting much of time, we have two speakers today. We'll be talking on hypoglycemia, neonatal hypoglycemia and hyperglycemia, and the practical issues what we face in while practicing in neonatal ICU. So initially, first talk will be by Dr. ABHISHEK, who is a consultant neonatologist and a pediatrician at OM Hospital, young dynamic guy, and followed by Dr. APURVA, who will be talking on hyperglycemia. So first ABHISHEK is going to make us have hypoglycemia, followed by APURVA will be making us hyperglycemia. And with discussion, we're going to normalize our glucose. So today's session will be moderated by Dr. Shiv. So we welcome one and all. Dr. ABHISHEK, over to you. Please start the session.
Thank you, sir. So hope Zoom server doesn't have hypoglycemia like yesterday. With that, let's begin the session today. So good evening, everybody. So I would like to acknowledge my teachers where I learned both pediatrics and neonatology at EJMER Chandigarh, as well as I would also like to acknowledge the place where I'm currently working and continue to learn neonatology and the corporate dynamics, that is at OM Hospital. Objectives for today's presentation will be what's exactly the definition of hypoglycemia, who are the at-risk population, whom to screen, what is the reliability of point-of-care devices, how do we manage hypoglycemia, what are the outcomes when it comes to recent studies, when do you actually label a neonate as persistent hypoglycemia, and how do we manage it medically as well as with surgical management. Everybody would agree with me that definition, clinical significance, and management of hypoglycemia is always controversial. It varies from consultant to consultant, the way they manage. But what everybody agrees is symptomatic hypoglycemia always causes poor neurological outcome in at least half of them. And prevention of hypoglycemia is always in our hands. We should be monitoring hypoglycemia carefully for at-risk neonates to prevent. Prevention is always better rather than managing a CP child in follow-up. With that, let's move towards definition. The literal meaning of hypoglycemia is low level of glucose in blood. Unfortunately, this low level, that is the level which maintains CNS integrity, is unknown. And we also do not know what is the safe level at different time points with respect to gestation or the comorbid conditions like sepsis or asphyxia is unknown. So there are many unknowns or the safe level for this so-called low level. So let's see how do we define hypoglycemia in different ways. So should we have a clinical definition? As we all aware of Whipple's triad, that is, you have symptoms of hypoglycemia that is accompanied by low blood sugar, and on treating it, the symptoms as well as the sugar normalizes is what we say as clinical definition. If you remember, the clinical definition has symptoms to it. How do we pick up asymptomatic hypoglycemia then? As we are all aware that we need to pick up hypoglycemia at the asymptomatic stage rather than the symptomatic stage. So unfortunately, we will not be able to use clinical definition. So what exactly is metabolic definition of hypoglycemia? As we are all aware that whenever there is hypoglycemia, physiologically there is release of counter-regulatory hormones, especially steroids, glucagon, and others. So if somebody has to use a metabolic definition, they have to measure glucose as well as they have to measure the release of counter-regulatory hormones. Practically, measurement and turnaround time of these hormones will take a long time. So it will be tough to use a metabolic definition in the clinical practice. What if we start using statistical definition just like we use for other conditions? Statistical definition, I say, let's say the blood sugar is below -2 standard deviation. If you start using statistical definition, it doesn't take into account the biological difficulties. Let's say a baby is born and in the first 6 hours of life, during the transition, they can have varied low levels. If you start accepting these low levels, it may cause over treatment. So I would say that statistical definition would not be biological, so we'll not be able to use statistical definition. Everybody are aware that with the advanced technology, we are able to measure cerebral blood flow as well as somatosensory evoked potentials. If you start using that to check hypoglycemia, that is, if you start using neurophysiological definition, can we define hypoglycemia? There are few studies which has looked at relationship between low somatosensory evoked potentials and blood sugar below 47 milligram per deciliter. Unfortunately, there has not been any consistencies in the studies, so neurophysiological definition would still take time. What if we take a neurodevelopmental approach? We are all aware of Lucas study. Some of you must be aware that Lucas et al. Did a study in preterm neonates who were less than 1850 grams. He found that neonates who had blood sugar less than 47 were at high risk of developmental delay at 2 years of age. Unfortunately, this low sugar, the difference in neurodevelopment did not persist in long term, that is at 5 years or at 9 years. So unfortunately, we cannot use neurodevelopmental approach as well. So what everybody would understand is that clinical definition is not helpful. Metabolic definition by measurement of counter-regulatory hormones is not helpful. Statistical definition is not making a biological sense. Neurophysiological definition doesn't have consistencies across studies. And the neurodevelopmental approach is again losing consistency in the long term. With that, something called operational threshold has been given by various guidelines. That is, it says, it doesn't define hypoglycemia specifically. It says, at this value, you need to take an action. So at that value, we are going to manage these neonates. Let's look at the operational threshold given by various guidelines. So classically, we have been learning traditionally that blood sugar less than 40 as hypoglycemia. Most of us use glucometers. I think 40 should be the right cutoff. But if somebody is still using lab value, it will be 45. That is, it measures plasma glucose. If anybody is symptomatic and the blood sugar is less than 40, we call it as hypoglycemia. What if somebody is asymptomatic? I have given here the first 3 lines, American Academy of Pediatrics guidelines. In the first 4 hours of life, AAP says less than 25 as the cutoff for the action point, while 4 to 24 hours of life, it gives cutoff point as less than 35. This is because in first 4 hours, you must be aware that the newborn will take time for glycogenolysis, gluconeogenesis. So because of which they've accepted as babies asymptomatic. Beyond 24 hours of life, blood sugar cutoff is less than 45. After 48 hours, it is as like any other pediatric age group, the Pediatric Endocrine Society recommends beyond 60. I would say if a neonate is symptomatic or is having asphyxia, it is safer to target cutoff of above 70 milligram per deciliter. I think the operational threshold or the action points are clear. So let's try to compare American Academy of Pediatric guidelines, which came up in 2011, versus the Pediatric Endocrine Society guidelines, which came up in 2015. You should remember that both these guidelines are expert consensus, which hardly has much evidence for its support. So AAP says symptomatic less than 40, asymptomatic in the first 24 hours, that is first 4 hours, need to target more than 40, but you act if it is below 25. For 4 to 24 hours, you will act below 35, but you need to target beyond 45. But the Pediatric Endocrine Society uses a higher cutoff of 50 in the first 48 hours. Beyond 48 hours, it uses a cutoff of 60 milligram per deciliter. So if you look at why did they give this recommendation, they have extrapolated this data from pediatric age group. So everybody would agree with me that if you use a higher cutoff, you will end up with over treatment, thereby higher family separation and higher cost of NICU care for the family. So I think it is understandable that AP cutoff is better in the first 48 hours. Beyond 48 hours, we can use 60. I think it's better to have individualized protocols in each unit. So we were discussing about lower threshold. Is there any evidence for lower threshold? A couple of months back, we had this study published in NEJM 2020. That is, they have compared lower versus traditional treatment threshold. That is, they've compared targeting 36 versus 47 for treatment of neonatal hypoglycemia. They have enrolled healthy babies who were more than 35 weeks, who were infants of diabetic mother, small for gestational age, as well as late preterms in the first 48 hours. The time point of enrollment was blood sugar of less than 47 milligram per deciliter. They started treating if they attained threshold, that is 36 or 47, in two groups. You can see in the study population, 57% in the lower threshold and 47% in the higher threshold, that is the traditional threshold, had sugars less than 47. So when they started treating, even at 36, the long-term outcomes at 18 months with Bailey's 3 scores was similar. What I would conclude is that there is upcoming evidence for threshold as low as 36 in the first 48 hours. AAP, I think, used 36, 35 for the first 24 hours, but this study rightly says up till 36 as well for first 48 hours. I think we need more evidence for lower threshold. Probably that will be solved in upcoming years. So summarizing, hypoglycemia cutoff is variable with respect to various ages. Target blood sugar more than 45 milligram per deciliter. So who are the at-risk population? The main categories of at-risk population where we should not miss measuring blood sugar is preterms, especially late preterms, small for gestational age, infant of diabetic mothers, as well as large for gestational age. These are the main categories of neonates where we should not miss measuring blood sugars. So whom to monitor? So as discussed earlier, preterms, that is less than 37 weeks, SGA, LGA, infant of diabetic mothers, sick babies, that is asphyxiated babies, polycythemia, sepsis, those with shock, those with RH isoimmunization, infants on TPN, 2 hours post double volume exchange transfusion. This is because immediately after exchange transfusion, there is hyperglycemia, and because of the rebound hyperinsulinism, they develop hypoglycemia as late as 2 hours. And those neonates whose mothers received beta blockers, and those neonates who have midline defects. This is because neonates with midline defects are prone for hypopituitarism. So these are the group of neonates where we need to carefully monitor blood sugar in early life. We should also not forget certain syndromes to monitor blood sugar, because these syndromes can be associated with hyperinsulinism and thereby hypoglycemia. I think most of you would be thinking in your mind that this is nothing but Beckwith-Whitman syndrome, where there is gigantism, there is macroglossia as well. So these neonates or these infants would have enlarged tongue, they can have abdominal abnormalities, they can have low blood sugar and hyperinsulinism. So do not forget certain syndromes, especially with those with midline defects. So why do neonates develop hypoglycemia? especially at-risk neonates. So this is because either there is problem with glycogenolysis after birth, or there is problem with gluconeogenesis, or there is inadequate fuel, that is inadequate fatty acid utilization and ketone body synthesis for the brain, or it could be inadequate protein breakdown. So these defects in various pathways can lead to hypoglycemia. So this is because this also is the main reason why certain inborn errors of metabolism also end up with hypoglycemia. If you look at the physiologic mechanisms behind hypoglycemia, there are predominantly three mechanisms. That is hyperinsulinism, decreased substrate, especially in preterms or IUGR neonates, increased demand, that is in polycythemia or sepsis or inborn errors of metabolism. These are the three main pathophysiologic mechanisms. If you see inadequate glycogen stores, we see in prematures, SGA, perinatal stress, polycythemia. Hyperinsulinism, again you see in IDMs, asphyxia, as well as IUGR. It could be endocrine deficiencies or IEMs with respect to amino acid metabolism, glycogen metabolism, glucose metabolism, or fatty acid disorders. So summarizing, we need to monitor at-risk neonates, especially preterms, SGA, and infant of diabetic mothers. So we have learned about definition, at-risk population, when to monitor and how long to monitor. So this is the screening protocol advised by or recommended by American Academy of Pediatrics for late preterm, term SGA, infant of diabetic mother, and large for gestational age infants. That is, infants 34 to 37 weeks and SGA, you would screen between 0 to 24 hours. Those who are born to infant of diabetic mothers, those who are large for gestational age and born beyond 34 weeks, you would monitor them 0 to 12 hours. If they are LGA and born between 34 to 37 weeks, you would monitor till 24 hours. Remember, if they are symptomatic and anytime have a blood sugar less than 40, you would give them IV glucose. If they are asymptomatic, in the first 4 hours, you would try to give breastfeed initiation as early as possible, preferably within 1 hour of life, and you screen 30 minutes after the first feed. If the blood sugar is less than 25, you would give IV glucose. If blood sugar is less than 25, you would feed and check after 1 hour. And if it is less than 25, you would give IV glucose. If it is 25 and you have fed, if the blood sugar is 25 to 40, you would refeed the baby or IV glucose as needed. So you would target glucose screen more than 45 prior to routine feeds. And you would give 2 ml per kg 10D or IV infusion to achieve plasma glucose of 40 to 50. So symptoms you would be watching is for irritability, tremors, jitteriness, exaggerated moro, high-pitched cry, seizures, lethargy, floppiness, cyanosis, apnea, or poor feeding. This is about first 4 hours of life. Beyond 4 to 24 hours of life, you continue to feed the baby between 2 to 3 hours. Screen glucose prior to each feed. If the blood sugar is less than 35, you would feed and check the sugar again after 1 hour. If it persists below 35, you would give IV glucose. If it is between 35 to 45, you would refeed or give IV glucose as needed. So remember, you're having a lower target in the first 4 hours, as well as 4 to 24 hours, your target will be 35. So what about monitoring beyond 24 hours of life? So you will have to do pre-feed monitoring only in selected population. Continue monitoring only if the RBS was less than 45 in the first 24 hours of life. Otherwise, you can stop monitoring these babies. You continue monitoring in sick baby, especially asphyxia. This is because asphyxia with hypoglycemia is a dangerous combination because it can increase the chances of neurodevelopmental impairment by 18 times. Would also continue monitoring if the neonate is on TPN. Let's look at diagnosis. I think with the utility of point of care devices, it's become very easy to monitor blood sugar. It's a useful bedside screening tool by using glucometer. Glucometer utilizes glucose oxidase method. That is, when you add blood to the strip, the glucose is oxidized and a current is produced. The intensity of current is proportional to the amount of glucose present in the blood. You'll have to remember that the glucometers are designed to pick up hyperglycemia for the diabetic population. It is unreliable, especially if your blood sugars are less than 50 milligram per deciliter. You need to confirm low values with lab. If there is hypoglycemia, always remember to send lab evaluation and start treatment. Do not wait for the lab reports for initiation of treatment. You can always confirm low sugars later with laboratory. This is because glucometer is prone for errors. You can see 75% of times your glucometer can overestimate blood sugar by around 10 milligram per deciliter. It overestimates. Let's say the blood sugar reading what you get is 55 milligram per deciliter. It may actually be just 45. What if it is 50? You may be having a blood sugar of 40 and you may miss it. So remember, it overestimates by 10 milligram per deciliter. And if you do not wait for the alcohol antiseptic solution, erroneously it can cause high values. If you have polycythemia, you can have falsely low values. If there is hemolysis, you can again have falsely low values. So glucometer is prone for errors. So lab sugar is the gold standard for the diagnosis of hypoglycemia. So lab sugar again uses either glucose oxidase or glucose electrode, as in the case of our blood gas machines. It measures plasma glucose, which is 10 to 15% higher than whole blood. If there is delay in processing, the blood sugar or the plasma glucose can fall by up to 14 to 18 milligram per deciliter per hour. That's why it is preferred to use fluoride vial. In general, venous blood sugar is preferred. Capillary blood sugars can have lower values, while arterial can have higher values. So venous blood sugar is the preferred way to analyze blood sugar. Recently, there is interest with continuous glucose monitoring systems. This is subcutaneous glucose oxidase based platinum sensors wherein interstitial glucose is catalyzed and electrical current is produced every 10 seconds and an average of 5 minutes is displayed on the monitor. So this is a comparison between capillary glucose versus continuous glucose monitoring. If you see, number of hypoglycemia per patient is, you can pick up 2 times higher if you're using a continuous glucose monitoring. Let's say you monitored blood sugar at around 12 o'clock. Again at 6 o'clock, your blood sugars are normal. But if you have a continuous glucose monitoring device, you can actually pick up hypoglycemias in between as well. So continuous glucose monitoring actually picks up more number of hypoglycemia episodes and thereby better neurodevelopmental outcomes. Unfortunately, this is still an upcoming modality. Still, I would say it's a research tool, but whatever limited evidence we have, the ability of continuous glucose monitoring device is higher in picking up number of hypoglycemia episodes per patient. So for hypoglycemia patient, is just blood sugar enough? Should we do any other additional evaluation like insulin or cortisol with any episode? Most of the hypoglycemia, what we would see are transient variety hypoglycemia. That is, they would settle down in the first 24 to 48 hours of life. We need to send additional evaluation only if you are suspecting refractory hypoglycemia, that is GIR requirement beyond 12 milligram per kg per minute, or if it is prolonged hypoglycemia, that is extending beyond 7 days of life. Remember, sampling time is critical for additional evaluation for hypoglycemia. Usually it is advised to send evaluation for insulin cortisol beyond 48 hours because transient hyperinsulinism is also known. And blood sugar less than 40 is the critical timing to measure blood sugar. So the additional evaluation can range from various steps. That is, step 1 would involve insulin cortisol, beta hydroxybutyrate, free fatty acid, TCV, sepsis workup. Step 2 would involve IM workup as well as endocrine workup. Step 3 would involve genetic testing as well as Doppler PET scan for pancreas. So it involves various steps of evaluation if you are suspecting refractory or persistent hypoglycemia. So summarizing, confirm low values on glucometer with labs. Additional evaluation is helpful only in selected cases. So let's discuss how do we manage if we have hypoglycemia. In a baby who is symptomatic or blood sugar is less than 25, you give a bolus. In asymptomatics, it's better to avoid bolus. Start GIR at 6 milligram per kg per minute. Target blood sugar beyond 16 milligram per deciliter. Increase GIR by 2 milligram per kg per minute every 15 to 30 minutes if the blood sugar remains less than 60. It is preferable to use peripheral line if our dextrose concentration is less than 12.5%. It is preferable to have 2 lines as well. Continue feeding. This is because breast milk is a good source for ketones for the brain, and it also releases counter-regulatory hormones. So it is preferable to continue minimal enteral nutrition while managing hypoglycemia. So how do we calculate GIR when baby is on for the management of hypoglycemia? We are all aware about calculation for dextrose percentage, that is 144 into GIR in milligram per kg per minute divided by volume to be administered in ml per kg per day would give the dextrose percentage. So how do we calculate GIR? Many people would still traditionally using X plus Y is equal to the amount of fluid required with complicated calculations. I agree it is complicated, but these days with the availability of various apps, it's become easy in NICU, reducing the errors in calculation. We can also use dextrose table or the dextrose concentration table, which is easily available in most of the textbooks or the apps. So you can use any methods, and remember that it is prone for error. It's better to doubly check the GIR before actually administering to the child. So we start tapering blood sugar once blood sugar is beyond 60 milligram and stabilized for at least 8 hours. We usually taper by 1 to 2 milligram per kg per minute every 6 to 8 hourly and increase feeds accordingly. Once we attain GIR of 4, you can directly stop glucose infusion rate. I think some of you would have heard about prevention of hypoglycemia by using dextrose gel. So this was a very good study published in Lancet a couple of years, almost some 7 years back, called the Sugar Babies study. In this study, they started enrolling neonates at risk for hypoglycemia when they developed asymptomatic hypoglycemia. That is, they enrolled stable, healthy, stable babies beyond 35 weeks if they had blood sugar below 47, and they applied dextrose gel onto the tongue of these babies, which was 40% dextrose gel. There was 43% reduction in NICU admissions for the treatment of hypoglycemia in this study, and there were no serious adverse events. So the last Cochrane also had the same single study which says that dextrose gel can be used for prevention in at-risk population. I could also find an Indian study in the clinical trials registry from CMC Vellore. This trial is completed and it is yet to get published, and they have studied in infants of diabetic mother. Probably in years to come, will have at-risk babies who will be given dextrose gel, preventing them to get admitted in NICU for GAR. So summarizing, start GAR if at 6 milligram per kg per minute and target beyond 60 milligram per deciliter. What about neuroimaging in hypoglycemia? There is no need to do routine neuroimaging for neonates with hypoglycemia unless you are suspecting additional cause or you have a doubt in the cause of seizures. If you do neuroimaging in the form of MRI in the hypoglycemic neonates, the common pattern what we would see is restricted diffusion in occipital cortex, optic radiation, and corpus callosum. This is because these areas would require higher calories in the brain. You can see restricted diffusion in these regions. If you look at hypoglycemic brain injury compared to asphyxial brain injury, brainstem and cerebellum are relatively resistant in hypoglycemic brain injury. There are some studies which says cortical involvement, middle cerebral artery infarct, basal ganglia thalamic involvement is also known in hypoglycemic brain injury, but they are rather uncommon. So hypoglycemic brain injury would have brainstem and cerebellum, which is relatively spared. So what if we do MRI? Can we really predict neurodevelopmental outcome in the long run? I could get this study from Burns et al. Done a decade back in 35 term neonates with symptomatic hypoglycemia. In this study, they found that out of 35 neonates, 8 neonates were normal, 15 had mild impairment, and rest 11 had moderate to severe impairment, in which 25 did not have motor disability, rest 9 had motor disability. Cognition wise, half of them were normal, rest half had some cognitive disability. 1/3 had seizures, 1/3 had microcephaly, and at least 1/3 had some visual impairment. So what is clear from this study is motor disability is around 1/3, I would say. Cognitive and seizures affection is around 35% in this limited sample size of 35 neonates. Child outcome study done by McKinley et al. Published in 2017. They actually followed all neonates who had blood sugar of less than 47 milligram per deciliter, and they followed as long as 4.5 years. You can see it is clear that neurosensory impairment in neonates they compared neonates with normoglycemia as well. They had control population. You can see neurosensory impairment is not there in neonates with hypoglycemia. Hypoglycemia primarily affects visuomotor difficulty, and it also affects executive dysfunction. Executive dysfunction is planning things, anticipating things. So those things are affected if you have severe hypoglycemia. This study actually defined severe hypoglycemia as blood sugar less than 36 milligram per deciliter. So if you have neonates who had less than 36, there is high risk of having visuomotor disability or executive dysfunction at 4.5 years. This is from a single study. Let's look at a systematic review of 11 studies published till now, which was published in 2019. If you look at by 2.5 years of age, this is a busy table. Visuomotor neurodevelopmental impairment, there is no difference. You can see 95% confidence interval is crossing 1 or it is below 1. Only visuomotor impairment and executive dysfunction is affected by 2 to 5 years of age. Epilepsy is also not getting affected with hypoglycemia. Visuomotor, executive dysfunction. If you look at 6 to 11 years, we have limited study. That is, we have only one study which have a long-term outcome as long as 11 years in a sample size of 1395 children. It says that the risk of low language or language delay would be 2 times higher. Low numerical disability will be as high as 2 times. So if you have hypoglycemia, you end up with visuomotor dysfunction, executive dysfunction, language delay, as well as low numerical abilities. So summarizing, there is predilection for hypoglycemia to affect posterior regions in MRI. It affects visuomotor and executive functions in the long term. So let's move on to the last topic of today's discussion, that is refractory and persistent hypoglycemia. Refractory hypoglycemia is defined as requirement of GIR beyond 12 milligram per kg per minute. Generally, we need to draw critical sample once blood sugar is below 40. That is, we need to send lab sugar, insulin, and cortisol. Apart from GIR, increasing GIR and central line, we may have to require hydrocortisone. Some cases we may have to require to give glucagon, IV or IM. You may even have to give octreotide if the hypoglycemia is resistant. Sometimes even polycythemia is also known to cause refractory hypoglycemia. So what exactly is persistent hypoglycemia? More commonly, persistent hypoglycemia is associated with conditions. Generally, we define persistent hypoglycemia if the need for glucose infusion persists beyond 7 days. Although some textbooks will also give persistent hypoglycemia as long as 14 days. I know to manage a neonate with hypoglycemia for 14 days is very tough for all of us. So generally, most of the books give as 7 days. We would stand with this, that is persistent hypoglycemia is glucose infusion persisting beyond 7 days. More commonly, it will have any of the 3 causes: hyperinsulinism, endocrine causes, or inborn errors of metabolism. I know everybody would be scratching their head, what is exactly the cause whenever we encounter such a case once in a month or once in 2 months, depending upon load to your NICU. Let's look at how do we easily differentiate various causes of persistent hypoglycemia. That is, let's differentiate hyperinsulinism, endocrine causes, and IEM. Let's say a persistent hypoglycemia, you would send a critical sample. You would also send lab test for insulin, beta hydroxybutyrate, free fatty acid levels, cortisol, growth hormone, and lactate. If you get a value of insulin which is high, I'll come back what exactly is high insulin or low values. High insulin, low beta hydroxybutyrate, low free fatty acid, and you further measure ammonia values. If your ammonia is normal, it could be perinatal stress like HIE or genetic causes. If the ammonia is high, it can be activating mutations of glutamate dehydrogenase. So if you have a high insulin, if you have a high ammonia, then it is glutamate dehydrogenase activating mutations. This differentiation is important because neonates with high ammonia, high insulin are the ones which respond to diazoxide. If you have neonates with high insulin but normal ammonia, they respond poorly to diazoxide. You may have to consider PET scan and pancreatectomy for this group of neonates. I'll come back to this later. So what if there is low insulin? If there is low insulin and higher free fatty acid, we generally look at ketones, beta hydroxybutyrate. If there is ketone production is affected, then the diagnosis is simple. It is fatty acid oxidation defects. If our ketone production is normal, you look at lactate values. If lactate is high, it is IEM, either glycogen storage disease, organic acidemia, or gluconeogenesis. If our lactate is normal, if our free fatty acid and ketones are high, it is endocrine cause. So I hope I am clear. If you have a case of persistent hypoglycemia, high insulin, high ammonia, they respond to diazoxide. High insulin, normal ammonia, it is a surgical cause of persistent hypoglycemia, rarely a fatty acid oxidation defect. If you have hyperinsulinism, if you have persistent hypoglycemia, low insulin, low ketones, fatty acid oxidation defect, low insulin, normal lactate, endocrine cause, low insulin, high lactate, IEM. Hope I'm clear about the differentials about persistent hypoglycemia. So what exactly is hyperinsulinism? So this is from Clinics in Perinatology, which defines whenever plasma glucose is less than 50 milligram per deciliter, if you have low beta hydroxybutyrate, you have low free fatty acids, plus minus detectable insulin. This is because in the face of hypoglycemia, any detectable insulin is called as hyperinsulinism, because in presence of low sugar, our body should not produce insulin. Any detectable insulin, we call it as hyperinsulinism, although there is controversy that various textbooks mention that if you have insulin values more than 2, we call it as hyperinsulinism. If you have a positive glycemic response to glucagon, we call it as hyperinsulinism. Of course, we need to exclude neonatal pan-hypopituitarism, that is cortisol beyond 10 mics, growth hormone beyond 7 nanogram. This is as per Clinics in Perinatology guidelines for hyperinsulinism. I know many would follow different cutoffs, but this is one of the best one which I could find. Let's look at what exactly is hyperinsulinism, or what exactly happens inside a beta cell of pancreas. This is actually a beta cell of pancreas. Glucose enters GLUT2 receptor of the beta cell. Once it enters, it is metabolized by glucokinase, undergoes glycolysis, and forms ATP. Let's forget all these steps. Next point to remember, this increased ATP will actually close potassium channel. Once the potassium channel is closed, there is depolarization. Once there is depolarization, there is calcium entry into the beta cell, which actually releases insulin. ATP closes potassium channel, calcium entry, insulin release. This is a normal step, what happens when glucose enters the beta cell. There is some additional mechanisms like in pathological conditions, that is genetic defects of sulfonylurea receptor, KIR 6.2, ABCC or KCNJ mutations of potassium channel. There is problems with this potassium channel, and the potassium channel is opened up. It is closed, and there is continuous depolarization, and there is continuous insulin release. Another mechanism of hyperinsulinism is if you have an activating mutation of glutamate dehydrogenase, again there is increased ammonia production. I think now you remember why we were stressing on ammonia values in activating glutamate dehydrogenase mutation, because there is increased ammonia production as well as increased ATP, and this will again close the potassium channel, and there is insulin release. This is what happens in hyperinsulinism compared to a normal beta cell. So how do we treat this hyperinsulinism? I think everybody would agree with me that if you have activating mutations of glutamate dehydrogenase, you can block this step by using diazoxide. If there is potassium channel mutation itself in KIR 6.2 or KCNJ mutation, unfortunately your diazoxide cannot bind it, because diazoxide binds only to the sulfonylurea receptor 1. So in such cases, octreotide will work, because octreotide works on calcium channel. Calcium channel is blocked by octreotide. In situations of genetic causes of beta cell, octreotide is a better choice compared to diazoxide. So I think I'm clear with respect to hyperinsulinism mechanism as well as the pharmacotherapy in hyperinsulinism in two different situations. So we have already discussed diazoxide, which is given at 5 to 20 milligram per kg per day in 3 divided doses orally. Unfortunately, diazoxide causes fluid retention, hypertrichosis, rarely can cause eosinophilia, leukopenia, hypotension. As diazoxide causes fluid retention, diazoxide is commonly administered with chlorothiazide. Other drugs, if diazoxide is ineffective beyond 5 days, we use octreotide. I'll come back to diazoxide 5 days concept. Octreotide will inhibit, as we have discussed, as it acts on calcium channel. We either give it as subcutaneous or continuous IV infusion. Unfortunately, octreotide causes tachyphylaxis. It can also cause diarrhea. And lastly, we also have glucagon, which can be given subcutaneous or IV, and it can also cause vomiting and paradoxical insulin secretion as well. This is about the drug dose, mechanism of action, and adverse effects. There are certain drugs as well which people have tried, unfortunately has ended up with limited efficacy. That is steroids. If you start using long-term steroids for persistent hypoglycemia, you can end up with adrenal insufficiency, hypertension, bone demineralization. People have also tried calcium channel blockers like nifedipine, but efficacy is not that great in persistent hypoglycemia. People have also tried drug like sirolimus, which acts on mTOR pathway. Unfortunately, studies with sirolimus has shown increased infections. So these are the drugs which we need more evidence or do not have much efficacy with respect to managing persistent hypoglycemia. I would agree with you that in resistant hypoglycemia or refractory, you may have to use steroids, but not in persistent hypoglycemia. What exactly is diazoxide responsiveness? Whenever you initiate diazoxide, you may not get immediate response. We generally start at 10 to 15 milligram per kg per day in 3 divided doses. Unfortunately, diazoxide is not approved by Drug Control General of India at present, and it's not easy to obtain diazoxide in routine pharmacies. So considering all these limitations, still some of us, rarely we were able to get diazoxide. Occasionally, if you get initiated 10 to 15 milligram per kg per day, gradually increase by 15 to 20 milligram per kg per day over the next 5 days. If responsive, by day 5 of life, you would be off GAR. Most of the Western literature say about safety fast test for 12 hours. That is, you do not feed the baby for 12 hours, carefully monitor blood sugar. And if blood sugar is beyond 70, it says diazoxide responsive. I would say it's better not to try safety fast test. If you're able to go off GAR, you can say diazoxide is working. If you're unable to make off GAR by 5 days, that means you need to consider diazoxide unresponsive state. Consider genetic testing for ABCC8 or KCNJ11 mutations, because these are the 90% mutations of beta cell. Continue dextrose. You can use octreotide here because diazoxide will not work. We have learned this. You can plan for F-DOPA PET scan with the nuclear medicine team. What exactly F-DOPA PET scan does? When you do a F-DOPA PET scan, it actually accumulates the metabolite in kidney, bladder. It accumulates in pancreas if you have a diffuse disease called nesidioblastosis. If you have a diffuse pancreatic disease, you will end up with diffuse uptake of the metabolite. If you have a focal disease, you will have focal uptake in the tail of pancreas or focal area of pancreas. I think if you have a diffuse disease, you'll have to resect. Near total pancreatectomy is required, but if you have a focal disease, only you'll have to remove the lesion. So DOPA PET scan helps us to localize the lesion as well as plan further. Because focal disease has good outcomes, diffuse disease unfortunately doesn't have very great outcomes. If you look at surgical management, you'll have to do only when you have focal or diffuse disease identified on DOPA PET scan who fail medical treatment. Early days, we used to do pancreatic catheterization, laparoscopic catheterization, but these days you're just doing DOPA PET scan. Once you do lesionectomy, you do a frozen section and identify the extent of resection. Diffuse disease, you do near total pancreatectomy. You may also require gastrostomy tube placement for continued feeding. If you do near total pancreatectomy, most often they develop insulin dependent diabetes mellitus before 20 years of age, with a median age by 8 years of age. So surgery is not without any complications. If you look at outcomes, this is a study from Children's Hospital of Philadelphia, where they studied from 223 neonates, where they had both focal and diffuse disease. You can see focal disease, more than 90% were cured, and they required less than 50% pancreatectomy based on frozen section. If they had a diffuse disease, only 1/4 were cured, and majority of them, despite pancreatectomy, required treatment for hypoglycemia. This is because they did near total pancreatectomy. Few parts of pancreas was left out, and this parts per se had hyperinsulinism, which continued, and they continued to have hypoglycemia. And you can understand that if they had hypoglycemia, they ended up with poor outcomes as well. So if you have a focal disease, it's good. If you have a diffuse disease, despite surgery, you may end up with insulin-dependent diabetes mellitus as well. So summarizing, hypoglycemia cutoff is variable. Target sugar beyond 45 in asymptomatics. Monitor at risk population. It's better to prevent. Confirm low values on point of care, especially with labs. Additional evaluation is helpful in selected cases. Start GIR at 6 mg per kg per minute and target beyond 60 once you're on treatment. There is predilection for hypoglycemia to affect posterior regions in the MRI. It predominantly affects visuomotor and executive functioning in the long term. Refractory is when you require sugar beyond 12 mg per kg per minute. Persistent is when you require GAR beyond 7 days. Always rule out hyperinsulinism, endocrine cause, or IEM. If you have hyperinsulinism and elevated ammonia, it's a very simple diazoxide responsive case. If you have a diazoxide unresponsive case, that is which happens 1 in 50,000 cases, 1 in 50,000 live births, you may end up with doing genetic testing, PET scan, and surgery. We do genetic testing because it identifies focal disease again. We'll have to do genetic testing of the parents as well, which I missed out previously. That is, we need to do genetic testing, not to miss focal disease, PET scan, and surgery. Surgery, as we are all aware, it's better for focal disease. I thank NNF Karnataka State Chapter for giving me this opportunity to present hypoglycemia with you. Thank you. Over to you, sir. Prashant sir, over to you.
Yeah, thank you, Dr. Abhishek. So just stop sharing the screen. It was a wonderful and elaborative topic what you have taken, and this is something which is very common. A lot of questions are coming. We will take up that later. So I request Dr. APURVA to start sharing the slides. So that we'll move on to the next topic, that is neonatal hyperglycemia. Dr. APURVA, over to you.
Hello.
Yeah.
So when I talk to my residents, my postgraduates or students, and I give them 2 blood gases, one of the blood gas has a PCO2 of 60 and the other blood gas has a PCO2 of 25. And I ask them, which is worse? Invariably, almost always they pick up a PCO2 of 60. It's just somehow that high CO2 is much worse as compared to an extremely low CO2. My aim for today's lecture is highlight the importance of how hyperglycemia, just like respiratory alkalosis, can be equally, if not worse, than hypoglycemia. I want to first of all thank everybody at the NNF Karnataka to giving me this opportunity to talk to all of you guys, to share some of my thoughts regarding neonatal hyperglycemia. And with that, I want to begin my presentation. Now, I'll be basically in today. Hold on one second. All right, I think I'm also visible. Okay. Now, I'll be basically talking about neonatal hyperglycemia in 5 different topics. In introduction, I'll talk about some very, very basic physiology, a touch upon glycosuria. In causes, I'll be dealing maximum with by far majority causes, which are not as many as hypoglycemia. Caution is where I would talk about what are the ill effects of hyperglycemia in the different neonatal morbidities. In controversy, I'll come to management. As part of controversy, one thing I would want you guys to do is there's a poll over at your Zoom app. When you click, there's a poll option there, and I would like you to do that poll. When we'll be discussing management, I would love to see the result of this poll. And in conclusion, we'll talk about just some small take-home points with respect to hyperglycemia. Now, going forward with terms of introduction, now glucose supply and its metabolism are essential. They are the central cornerstone for growth and development, particularly with respect to brain. As we all know, brain growth is extremely important for our neonates, particularly in preterm, and about 70 to 80% of glucose get utilized with the brain. Now, as true with hypoglycemia, even hyperglycemia definitions are kind of arbitrary. Majority of books and literature that you will pick up, you will find that they define hyperglycemia as anything above 150. As pretty much all of us would agree, we have seen more than 150 values a lot of time. And plus, this value does not take gestational age in account. It's, as I said earlier, it's extremely arbitrary, and somehow the definition is not suggestive of the defining value. There is a talk among the scientific world that what value is acceptable and what value is not. During the various studies that I'll mention, different studies have taken their own different cutoff point. So some have taken 180 as a cutoff point, some have taken 150, but there is no study that tells that beyond X value, the chances of complications are high. For each study is sometimes usually different. Now coming on to when does this happen? Now, there was a study done in 1974. Yes, you have heard it correct, 1974. And in this, they looked at the babies who were born with a birth weight of less than 1100 grams. They found out that almost 86% of these babies had hyperglycemia. Coming to present time, in 2018, there was an express trial that was published in Journal of Pediatrics. This was a study done in Sweden. And in that data point, even though we are much better now with respect to hyperglycemia management, but with the increase in preterm deliveries, the rate was still as high as 70%. And out of this, almost half, about 50% of babies had hyperglycemia for more than 2 consecutive days. Now, the incidence is extremely high. So it's much more than hypoglycemia in certain cases. But it's also inversely related to birth weight. The more preterm the child is, the more likelihood that the child will develop hyperglycemia. This is also extremely common during the first few days of life. But as most of us who take care of these preterm babies, this can happen at a later stage, even as long as 4 weeks of life. That is up to 28 days of life. Now, going forward, there are 2 terms that I want to really discuss. One is with respect to glucosuria, and another is with respect to hyperosmolarity. Now, any patient, be it adult, pediatric, or neonate, the glucosuria will depend on 2 aspects. These fundamental aspects are, what is the degree of hyperglycemia in this patient? And second, what is the renal tubular resorptive capacity? In other words, how much sugar do you have in the blood and how much the kidney can absorb? Now, unfortunately, newborns do not have a very good resorptive capacity. And this gets even worse when they are sick or when they are preterm. Majority of our preterm babies are sick, unfortunately. So that's the reason that glucosuria in itself, just on its alone, cannot be taken as a good marker for hyperglycemia, because some near-term or term babies whose renal tubular capacity is well developed might not exhibit glucosuria even in case of hyperglycemia. But when used in conjunction with other tests, it's extremely beneficial, and we'll talk about it, when to use it and how to use it. The second aspect is hyperglycemia is one of the worry is osmotic diuresis, that there's hyperglycemia and there's hyperosmolarity leading to increased urine output and all the other things. Just to give you a context, plasma osmolarity increases by 1 milliosmol with an increase in glucose by 18. So to give you an idea, if the sugar jumps from, let's say, 100 to 200, the relative increase in osmolarity would be only about 5. So unless and until your sugar levels are extremely high, more than 400, more than 500, there will not be much clinical effect of hyperosmolarity with respect to hyperglycemia. Of course, if you have dehydration or high sodium, then the situation changes. But just in itself, the effect is only seen at really high levels. Now, going forward, just to give you a very brief idea about the type of assessment, Dr. ABHISHEK has mentioned this in detail, but the whole blood glucose versus the plasma battle even continues in hyperglycemia, just like in hypoglycemia. The thing is, when you measure whole blood glucose, its level is dependent on 3 things. What is the plasma glucose concentration? What is the glucose concentration in the red blood cell? And last but not least, what is the hematocrit? As in, what is the volume of the blood that has been occupied? So a plasma glucose concentration of 10 can result in a whole blood glucose of more than 10 if hematocrit is high, of 10 when hematocrit is within the normal range, or less than 10 if the hematocrit levels are extremely low. So we have to take hematocrit value in account when you're trying to decipher the whole blood glucose level. However, in plasma glucose concentration, its value is independent of hematocrit. So that's why it's much easier to interpret. As far as venous, arterial, and capillary, venous is one of the more safer way to obtain sugar. Capillary is one of the much more easier way to obtain. In a normal physiological state, the capillary levels are slightly higher than venous. That's just how it is. But each method has its own positive, its own negative. So you need to be clear why you are checking the sugar, and that is what is going to determine which type of sampling and what to analyze. Now going forward, what are the causes? Now before we deal individual causes, let's take a step back and look at how these causes happen. In a normal patient, the one who has absolutely normal glucose metabolism, whenever you give him an infusion of glucose, with or without amino acid, doesn't matter, there's a somewhat level of suppression of hepatic glucose production. Now, as the hepatic glucose production is suppressed, you will notice that secondary to the infusion of glucose, there is high circulating insulin concentration, which was in response to this high glucose. Now, this causes increased uptake of this glucose in liver and more importantly in peripheral areas like the muscle. So you have an increase in glucose for one reason, that is by the infusion, but thanks to hepatic and peripheral glucose uptake, this level has come down. And as a result, life is fine, you are normoglycemic. But majority of the time, this is not so in our neonates. Our neonates, unfortunately, are troubled by 3 main issues. First of all, is they have a very poor insulin response. Secondly, they have incomplete suppression of glucose production. So no matter what the sugar is outside, they are not able to get the proper response in the liver. And last but not least, the counter-regulatory hormones, which are associated with stress. All our preterm, just like the doctors taking care of these preterms, have a lot of stress. And as a result, that's the problem. Now, going forward, the poor insulin response. Now, there was a study published in Pediatrics in 2004 where they evaluated insulin level of all extremely preterm babies. So they found that at a baseline level, most of these values were similar in extremely low birth infants. But as they noticed, the babies who developed hyperglycemia, their response to this high glucose value was not same as the babies who maintained to have euglycemia. Now, a hypothesis was postulated that in certain preterms baby or extremely low birth weight babies is defect in islet beta cells and their processing of proinsulin. And that is the result. They have a poor insulin response. But there are multiple studies that show that there's a poor insulin response, particularly in our preterms and in extremely low birth weight infants. Now, the second problem that we see is the incomplete suppression of glucose production. We all take care of extremely low birth weight infants. When they are born, due to their weight or the time of day they are born, or for various other aspects, they have insufficient protein intake. Because they have insufficient protein intake, in order to maintain their normal metabolism, they have to undergo proteolysis. This child, in order to maintain his or her own metabolic demand, has to break down his or her own protein. That's why the consensus is to give amino acids as soon as possible in preterm deliveries, especially for extremely low birth weight infants. However, in spite of that, these babies, their hepatic sugar is not inappropriately closes. So in spite of all of this that is going on, there's supplement of high glucose, they cannot shut down the hepatic production. As a result, they get extra sugar, one from their hepatic source plus from what they supply. And the combination of these two has then subsequently lead to what we see as in hyperglycemia. This is another cause that you see throughout the pathologies that we'll discuss today. The third, and definitely not the last, is the increase of counter-regulatory hormones. One of the most reminded physiology lecture I can say is where you have that picture where there's insulin on one side and 4 hormones on the other side. One is trying to balance the other, and the result of that balance is a normal sugar level. Now, unfortunately, our neonates are plagued with conditions that lead to increased stress, be it sepsis, be it resuscitation, be it extreme amount of interventions. They are in a state of constant stress. That's why their level of epinephrine and cortisol, this could be exogenously supplied or internally increased production secondary to all the morbidities, is high. And as a result, because of these counter-regulatory hormones, they have a high blood sugar level. Now, how are the individual cases are responsible with respect to these pathogenesis process? So the first and by far the most common cause is the parenteral administration of glucose. Anytime any child is receiving a GIR of about 10 or 11, almost all these babies will develop hyperglycemia. And again, these are the babies who are not receiving 10 to 11 GIR because of hypoglycemia. These are essentially normoglycemic, but every day with increase in fluids and glucose concentration end up receiving a high GIR, they will develop hyperglycemia. Now, in these conditions, the patients who are extremely vulnerable are preterms and IUGRs. Now, in these premature patients, what happens is they have a poor muscle mass. Because of the poor muscle mass, the peripheral utilization of glucose is extremely low in these patients. Unfortunately, among the IUGR, even their hepatic utilization of sugar is poor. As a result, they have a high hepatic insulin resistance. So first of all, you do not have muscle which can utilize this sugar. Second, there's a relative insulin resistance of hepatic nature. Both these factors lead to hyperglycemia in premature and IUGR patient. If you're premature and IUGR, that's a double whammy. You'll definitely almost always see hyperglycemia in this subset. The second reason why some of these babies develop hyperglycemia is delayed enteral feeding. One of the functions of enteral feeding is to release gastric hormone. One in particular is called incretin. Now, the function of incretin, among other things, also include stimulation of release of insulin. As a result, because incretin is not released, these patients can develop hyperglycemia. One thing, as I mentioned earlier, is these babies are often sick and under stress, and as a result have high blood sugar secondary to the counter-regulatory hormones. A rapid and high lipid infusion, which we do not see very common, at least in our patient population, but a high lipid concentration would also lead to hyperglycemia, because then all of a sudden the baby is exposed to the high circulating volume of free fatty acid, which then subsequently lead to hyperglycemia. So if you start lipid infusions, please start at a smaller level and gradually go up. Now, one cause that I would especially want to highlight, if you want to remember just one cause from today's lecture, that would be sepsis. We have particularly seen hyperglycemia as the only sign in an infant who then subsequently developed sepsis, who previously had normal blood glucose concentration. Thankfully, our rate of hyperglycemia is very higher than the rate of sepsis. But remember, prevention is better than cure. And if you can't prevent, early recognition of sepsis is always, always better than late. As a result, be very, very cautious of hyperglycemia when it occurs in a preterm child, especially when the sugars were previously normal. Anytime I tell, like, you need to have 1+1, hyperglycemia with maybe some increased oxygen requirement or some abdominal distension or some subtle sign of sepsis can lead to early recognition and thus early intervention. Among the sepsis itself, the fungal infection has a very high association with high blood sugars as compared to bacterial. But just because bacterial sepsis is so far common, we still end up seeing much more high blood sugar with bacterial sepsis as compared to fungal. Going forward, some other causes, and this we commonly see: a baby that comes from surgery, stress leads to high sugar. Postictal, a seizure, baby has just had a seizure, secondary to that there is high blood sugar. Any kind of perinatal insult or stress right before the delivery or right after the delivery in form of an extensive resuscitation can also lead to hyperglycemia. As being in NICU, we have to deal with a lot of medication, and some of the common medication that we use, particularly the methylxanthine, can lead to hyperglycemia. Steroids and beta-adrenergic, especially dopamine, epi, norepi, will lead to hyperglycemia. And as such, you need to not necessarily know that how much the hyperglycemia would be, but just to be ready with a degree of hyperglycemia, that this hyperglycemia can be because of drug rather than for other reason. Phenytoin is another drug that leads to hyperglycemia. The exact cause is not really elucidated so far, but it might be with respect to suppression of insulin release or changes in insulin sensitivities. Last but not least is neonatal diabetes mellitus. Now, this is usually a monogenic disorder which is caused by mutation in a gene that encodes protein for pancreatic beta cells. Thankfully, this is extremely rare. I've so far seen like one case, but it's extremely rare, but something that we need to keep in mind when the patient has persistent high sugar values. Once we discuss the cause, going forward, we need to be aware of where the caution has to be taken. Now, caution has to be taken with respect to hyperglycemia, just as I was mentioning in case of respiratory alkalosis, because hyperglycemia has shown to affect every condition that has been listed in this slide, along with others. Now, its effect on overall morbidity and mortality, there was the study done by Gull et al. And was published in 2017. They had about 192 babies, out of which they did sort of a study and a control group. They had 96 babies who developed hyperglycemia and about rest of the babies who did not. And they compared between the two groups, how was the incidence of IVH, NEC, and infection. And they found out that hyperglycemia was associated with higher incidences of IVH, NEC, infection. Now, again, this does not say that the hyperglycemia was causative of these things. It might be an association, but still it was present. They also noticed that hyperglycemia babies had higher mortality and ended up staying in hospital for much longer time. Now, going forward, there was another study that was published by Van der Lut in Netherlands, where they tried to look, let's see what is the short-term and long-term effect of hyperglycemia. Now, in this study, what they saw, this was like a retrospective follow-up. And they had a total patient population of around 860 patients. And these 800 patients, 860 patients, were less than 32 weeks of gestation. And this was, as I mentioned, a retrospective review. And they kind of saw that how many of these patients were treated with insulin. Now, in a short-term follow-up, that is till the NICU discharge, they saw that the patients who were treated with insulin and had hyperglycemia, they had higher mortality. So first of all, they had a very high mortality. Second, among 33 kids who were able to discharge from the hospital at 2 years of age, they had about normal growth as other patients who did not receive insulin and did not develop hyperglycemia. But these babies had higher incidence of neurological as well as behavior problems. Now, this pattern is seen in multiple studies. This particular study was just presented at a conference and is available on PubMed, where they saw that the babies who developed mild to moderate or severe hyperglycememia in the first week of life, when they did a follow-up, they found out that their Bailey scores were much lower, particularly of the motor domain. And then if they develop mild to moderate or severe hyperglycemia, within the first month of life, they still had lower motor score. In other words, that the motor domain seems to be most affected by hyperglycemia. However, it's not just the only domain, as language and cognitive were noted in other studies. Now, going forward, hypoxic ischemic encephalopathy. Now, HIE is one of the most common morbidity that we deal with. Thankfully, due to therapeutic hypothermia, we can prevent or at least contain a lot of the damage to these babies. It's an absolute, studies have shown again and again that how it's such a wonderful modality. Now, hyperglycemia has association with HIE as well. When you see among HIE patients, this was a fascinating study that was done at Sick Children, Toronto. Now there, what they did was any baby who was getting cooled had an AEG, and what they did was they started to notice their glucose level. Now, what they found was they had about 45 infants. The mean gestational age was around 39 weeks, so very similar to our patient population. Now, during the AEG monitor, they found that they had about 16 periods of hypoglycemia. During the periods of hypoglycemia, the waveform or the rhythm of AEG did not change. However, they also noticed that there were about 18 episodes of hyperglycemia. During the episodes of hyperglycemia, they noticed that the AEG got worse. Now remember, this is a prospective study. So they noticed there's a global brain dysfunction and even seizures during these times of hyperglycemia. Now, when they adjusted this to hypoxic ischemic severity, I mean, it could very well be that the patient who developed hyperglycemia just might have worse HIE. But when they adjusted HIE component or the severity of it, they found hyperglycemia to be independently significant. In other words, any baby who is having HIE or is suspected to have, we should definitely prevent hyperglycemia from happening. Now remember, this is a prospective study. In a retrospective analysis, which was published by Dr. Chautai in 2015 at Journal of Neonatal Perinatal Medicine, about 9 infants in therapeutic hypothermia group. So they divided babies who had HIE features but received therapeutic hypothermia and who could not receive for some reason. Now 9 patients developed blood glucose level of more than 200 in this cohort, 9. And 9 out of 9 had either mortality or ended up developing moderate severe disability, compared to only about 50% when the blood glucose was less than 200. Let me repeat that sentence again. 100% of infants whose blood glucose level was more than 200 during the first 24 hours receiving therapeutic hypothermia had either died or had moderate to severe disability, compared to only about 54% whose sugar was less than 200. So if your sugar was less than 200, chances of having death or severe disability was about 54%. But if your sugar was more than 200, that chance shot up to 100%. So in certain cases, if it's persistent, And depending on the history and the clinical features, it can even be prognostic too. They also notice that it's not just the high blood sugar, it's actually the variability, that it's not just the high, it's how many times it goes low and then how many times it shoots up again. The variability, that is also associated with poor neurodevelopmental outcome. So glycemic control, especially in our HIE population, is extremely, extremely important. Going forward, ventilator requirement. Now, this was a review done by Bana Zande and was published, had about 112 patients, which is a significant number given the vulnerability of this population. They noticed that the duration of hyperglycemia was positively associated with mortality as well as ventilator dependence. So babies who had hyperglycemia for a longer time ended up staying on the ventilator for a longer time. And this, in fact, was seen with mortality as well, as we mentioned in the earlier study. Now, as I mentioned, hyperglycemia has association with very high morbidity and in certain cases, high mortality. So then where is the controversy? So the controversy lies in terms of management. So let me try to pull up the poll that I created and see what the response. So the poll I created, I don't know if you guys are able to see poll as my screen, but the question was, at what level of glucose would you consider treatment with insulin? Option 1, more than 200. About 21% of you voted that you would consider treatment with insulin for any sugar greater than 200. Number 2 option, which was more than 250, 42% of you agree. This is by far the most common response. So 42% of you wants to treat an insulin if the sugars are more than 250. 300 or more sugar level and insulin treatment was preferred by 20% of you. So about 40% want to treat for 250 and above, 20% want to treat more than 200, 20% wants to treat more than 200. About 10% of you want to treat more than 350, and 10% of you do not use insulin regardless of the level. Now, I've shared this poll results with all of you so that you can also review these poll results. And that's where the controversy is. What is the right level to treat? Now, as you notice, even the consensus among high values is not well established. Dr. Abhishek very eloquently spoke about which level do we consider treatment. But at least most of them agree that less than 25, we all should treat. But here, some of you do not consider treating even at 350. And again, it's nothing to do with us as a neonatal population. I think this kind of survey would be shared even when you do it in a different scope, when you do it all over the country. So how and when do you manage this insulin level? As far as how goes, I'll show you sort of my clinical preference and what I have gathered from different review articles and stuff. That will be pertaining to when. In majority of cases, anything which is above 250 on a consistent basis would definitely require treatment. Now, how do you do the treatment though? The easiest step to go forward would be to reduce the glucose infusion rate. So in this flowchart, this flowchart has been created by me, it's been trying to summarize different review articles. So you might find information in there which is not consistent with one or the other reference article, but this is just my interpretation of all the knowledge that I have compiled. So if you have multiple values of 250, greater than 250, and when I say multiple, definitely at least 2 or more. If you just have one off value, I would not trust it. I could even go, you can convince me of 4 or more or 3 or more, depending on how frequent you take them. Now, you have the multiple values, you have signs of sustained hypoglycemia. First and foremost, you need to investigate the underlying etiology. The 3 common etiologies that you should rule out at a preliminary stage is first and foremost sepsis, just because the morbidity and mortality is so high if you do not recognize at an earlier stage. Second is stress and pain, which sometimes becomes a sort of a diagnosis of exclusion. And third is medication, the medication that we discussed earlier. Now, if any of these 3 turns out to be positive, you start with treating the underlying cause. Sometimes just treating the underlying cause might do it, but in most of the cases, you have to go forward. How do you go forward? First and foremost, you can reduce the glucose infusion rate. Now, a small caution, and this is especially true for our less than 500 gram babies, less than 600 gram babies, try not to reduce the glucose infusion rate below 5. Regardless of the glucose values, the baby would need that much for peripheral utilization as well as brain. So please don't go beyond 5%. D5 is the minimum, should not go below it. And whenever you reduce the glucose infusion rate, please, please, please monitor the glucose level. Monitoring the glucose level is extremely, extremely important, because one thing that you do not want to cause as a result of treatment of hyperglycemia is hypoglycemia. And you do not want to cause a high variability in the glucose values. So please reduce and monitor. And if needed, then you can further reduce. The other investigation that can come in handy at this time could be, depending on, again, on etiology, could be the glucose in the urine. Certain centers might have facilities for insulin level. Depending on your etiology and what you're suspecting, that could be one of the cases. Now, suppose you try to reduce the GIR, and in spite of the lowest possible GIR that you can give, the child is still persistently hyperglycemic. Again, I took the value for my cutoff as 250. My cutoff value is also not absolute. It depends on what are the associated comorbid condition of the baby, what is the gestational age and weight of the baby, also what kind of access I have with this baby. Now, if thankfully the level is between 150 to 250, I would continue the current management. And if the level for some reason is now less than 150, please, please, please be wary of hypoglycemia. And I would rather have the sugar little bit high rather than low, just based on data that I have. But again, where you want to stay is somewhere between this range, preferably between 125 to 175. That would be even sweeter. Now, the thing about insulin therapy that we need to know is, first of all, threshold for treatment. Like I said, as reflected by your polls, your threshold of treatment vary. And I'm sure with more and more clinical features that are available, the threshold might be different for different babies. If you do decide to treat with insulin, what we do here in the unit is we start with bolus first. Now, again, the dictum that I follow for insulin treatment is smaller the better. So ideally start at 0.05 units per kilo. And instead of, even though it's a bolus, don't give it in one shot. There's nothing like crashing, making a sugar value crash and go high up again. Please give it over slow infusion, preferably over 10 to 15 minutes. In our unit, we prefer to use regular insulin, as in type of insulin. Now, you can consider giving at least 1 to 3 bolus of insulin. And depending on your access, if the hypoglycemia still persists, still persists, you can consider continuous infusion of insulin. Now, at centers where I worked before, the continuous infusion that we used was mixed with D10 sugar, because you do not want to cause hypoglycemia. And please, please, please notice that the dose of continuous infusion, especially the starting dose, is much lower than what you would do as a bolus insulin. So you start at a lower dose. Then the important thing is monitoring. You have to monitor glucose every 30 to 60 minutes in a patient who is undergoing insulin therapy, whether it be bolus or continuous. Titration is paramount. Titration of both sugar as well as insulin. If for some reason you believe that the sugar did not come down or continues to rise, you can consider giving multiple doses. However, I would not make any incremental changes, maybe once every hour. And incremental changes should also be small and carefully monitored. Please make sure you have a glucose monitoring at bedside, which can be done frequently with availability of checking serum glucose while you are initiating the insulin therapy. Now, most of the time, hyperglycemia settles once you treat the underlying cause or after about 2 to 3 days of life. Majority of the time, it lasts for about 24 to 36 hours. Once the hyperglycemia is settling down, you can consider weaning your insulin therapy, particularly if it's a continuous infusion. Now, weaning can be done much faster. You can come down very fast on insulin level. Just you still have to check it, but it need not to be as slow as when you were grading up. Now, some other practical consideration while given insulin is that insulin tends to stick to the plastic tubing. So anytime you have a patient who is receiving insulin, please change the insulin infusion and the tubing at least once every 24 hours. If your pharmacy has different policy, please follow up your pharmacy policies, but at least once in 24 hours, it should be changed. Now, insulin also has interaction with many other medication while being infused through the same tubing. So please confirm that before you start insulin infusion. Last and extremely important, however, is that remember there's always insulin towards the end of the tubing, especially if you're using any kind of central catheter, be it umbilical or neck or femoral. So if you are trying to give, let's say, a purge of morphine, try to make sure that insulin is not going through the same lumen, because then your bolus of morphine or your bolus of fluid might also result in a bolus of insulin, which you do not want in this patient. So be extremely cautious with respect to interaction and make sure your nursing staff shares your level of caution while doing the insulin therapy. Now, going forward, if insulin is good so much, this was a fascinating study which was done in 2008. This was published in New England Journal of Medicine. In this, what they did was they basically divided their preterm patients into two groups. Now, what they did was they had about 195, almost close to 200 patients who received continuous infusion of insulin at 0.05 unit along with D20 to maintain a euglycemic for the first 7 days of life. Okay, so for first 7 days, 200 babies received insulin. They had another 200 babies who were controlled who did not receive insulin. And they wanted to see what is the effect of early insulin therapy. Now, the problem was they did find reduced incidence of hyperglycemia, but these patients had higher incidences of hypoglycemia. And unfortunately, even though they did not have much death during the first 7 days of life, but as you notice, within the first 28 days of life, within the first 28 days of life, the mortality in early insulin group was very high. Unfortunately, because of this result, this study had to prematurely close down before their full recruitment. But as you can see, the mortality was high that was noted among early insulin group. Now, I kept looking in PubMed and other places to see what is the follow-up data of these neonates. Unfortunately, I could not locate the follow-up data of these neonates, and it would be interesting to see what happened later on in terms of outcome for these patients who received early insulin, regardless of their development of hyperglycemia. Now, continuous glucose monitoring is another place of controversy. Dr. Abhishek touched upon it a little bit. Its role in neonatal glycemic control is extremely limited at this moment. It's limited only to research studies. But the study that I mentioned from New England Journal of Medicine actually had continuous glucose monitoring. Just like diagnosing hypoglycemia, continuous glucose monitoring was able to diagnose hyperglycemic as well. Now, the idea of researchers is that CGM or continuous glucose monitoring would open up an avenue where you could have a real-time adjustment of sugar values with respect to insulin, just like how they do it with diabetic adult patient. Your sugar is high, small amount of insulin will go in the body, will make the sugar normal. Now, unfortunately, there is not much data out there, but fortunately, the data is on its way. They did a pilot study for about 20 very preterm infants and found that there is possible to target glucose control with continuous glucose monitoring. So these babies were less than 1500 grams for extreme preterm babies. So at least it's feasible. Currently in Europe, they are planning to do the real-time continuous glucose monitoring in neonatal intensive care. Somehow they came up with the short form of REACT for this. And it's an international multi-center randomized controlled trial. Some of the members are same as that New England Journal trial, and they are trying to see how they can use this continuous glucose monitoring in extreme preterm babies to prevent hyperglycemia. I'm extremely looking forward to results of this study. So in conclusion, what I want everybody to take home message is that this condition is extremely common, especially in our extreme low birth weight babies and in our very preterm babies. Incidence could be as high as 70%, 80%. Recognition is important. Recognition is important because this can be associated with sepsis, and knowing is half the battle. If you're recognizing is, you can predict outcomes, especially if they are poor, especially when they're associated with HIE. And just like any other thing, prevention is better than cure. If you can prevent the hyperglycemia from happening by titrating your glucose, by starting early feeds, that would be the best thing you can do for your preterm baby. I again want to thank everybody. I would also like to give a shout out to the technical team yesterday. For a longest period of time, I thought my computer was responsible, but these people were working so hard in the background. Thanks again to everybody at NNF Karnataka. Prashant sir, over to you.
Yeah, thank you, Dr. Apur. I'm sure the participants have really enjoyed the session, both the sessions. So I request Dr. Shiv to moderate the session.
Sure.
There are a few questions. Dr. Shiv, over to you. And whoever wants to ask the question, they can post the question in the chat box. We will take up that questions. And few, you can raise your hands. Only few people whom we know, we will allow them to ask the question directly. Over to you, Dr. Shiv.
Yes, thank you, Dr. ABHISHEK and Dr. Apur. It was a wonderful session, I think, enlightening us on hyper and hypoglycemia. I hope all the viewers have been benefited. You guys have made the complex topics quite simple. So I've got a few questions for Dr. ABHISHEK to begin with. So, is hypoglycemia with seizures have unfavorable outcome than babies who are asymptomatic? Is there any difference between those two?
The traditional teaching is that symptomatic hypoglycemia, that is with seizures, will actually cause approximately 50% risk of having cerebral palsy. But recent studies from PGMA Chandigarh published in, I think, a couple of years back, they have followed up all units with symptomatic and asymptomatic hypoglycemia, and they found that roughly 1/3 were actually abnormal if they had seizures with hypoglycemia.
Oh, all right. Okay. I hope that answers the question. The next question is, when the brain can utilize ketones, why do hypoglycemia affect the brain? I mean, this is kind of an interesting question, but if you have any answers for us, I hope you have.
Yeah, it's an interesting question. So normally brain actually depends upon 3 major metabolites for energy production. So in general, it makes use of glucose 70 to 80% times. In state of fasting, it depends on 2 other metabolites. One is lactate, other is ketones. So that is the reason lactate will be partially elevated in the first 3 days of life, because roughly 10% of brain's energy depends on lactate and 10% also depends on ketones. So brain cells actually can utilize ketones roughly 20 times better than adult brain. So 10 to 15% of brain's energy, especially during stress or fasting, is because of ketones. And ketones can be produced only by breast milk compared to just giving glucose alone. That is the reason when hypoglycemia, we actually give minimal feeding along with glucose to provide ketones.
Sure. Thank you so much. The next question to you as well is, when do you check usually after giving an IV bolus in a symptomatic or asymptomatic hypoglycemic neonates? After giving a bolus, when do you ideally check? It's either 30 30 minutes, 45 minutes, or 15 minutes? Is there a cutoff to check?
So in general, most of these standard recommendations suggest to check 15 to 30 minutes after every change in blood sugar. So let's say you have blood sugar of less than 25, you give a bolus, you start glucose infusion, monitor every 15 minutes. I think logistically, sometimes it can be as high as 30 minutes as well. Ensure that you check 15 to 30 minutes after starting infusion. If normal, you would monitor hourly for the first 4 hours until it stabilizes, thereafter every 6 hourly. Hope it answers your question.
Yeah, it was quite clear. I think you have stated the recurrent causes of recurrent hypoglycemia. Do you just want to, one of the viewers have asked that question, just the causes of recurrent hypoglycemia, which you would concentrate on in day-to-day practice, the most common cause of recurrent hypoglycemia.
So recurrent hypoglycemia, usually, most commonly it will be because of transient hyperinsulinism or polycythemia in the first 48 hours of life. But beyond 48 hours of life, it is either hyperinsulinism because of perinatal stress, or it could be because of endocrine cause, or IEMs is the cause of persistent hypoglycemia. If you look at beta cell defects, it will be usually rare. It happens in 1 in 50,000 live births. So more common would be IUGR, sepsis, asphyxia, IEM, or endocrinal defects.
All right. So the next question is, what's the dose of hydrocortisone you use in a babies with hypoglycemia, and how often and how long you give?
Generally, hydrocortisone is used only in situations of refractory hypoglycemia. We generally use hydrocortisone of 10 milligram per kg twice daily. We generally continue until we come down on GIR, safe cutoff. That is somewhere, once you come down on GIR of 8 or 6, we generally taper off and stop. We generally taper off, especially in preterms, because we are worried about side effects of hydrocortisone in preterms. But in term babies, generally we taper off once we are at a GIR of 8.
Okay. There's another interesting question. Are there any inborn errors of metabolism which presents on day 1 when the baby is on IV fluids, not on any feeds, with hypoglycemia? Do you know any, or there's anything?
Yeah, hypoglycemia and inborn error of metabolism is altogether a big topic. So here you can see, especially with persistent hypoglycemia, we have already discussed fatty acid oxidation defects, organic aciduria, GSDs, and disorders of gluconeogenesis. But I would generally give you if you have hypoglycemia, especially hypoglycemia presenting on day 1, whenever you do not have risk factors, I think fatty acid oxidation defects will be the most common to watch out for. So usually beyond a week, it will be galactosemia. But remember, hereditary fructose intolerance can manifest on day 1, especially when you are using cow milk or formula feeds instead of breast milk. So hypoglycemia, if you are strongly suspecting IEM, go ahead with urine glucose reducing substances. If it is present, rule out galactosemia or fructose intolerance. If it is absent, do ketones. If ketones are not there, it is fatty acid oxidation defects. If ketones are high, generally on day 1, you can have GSDs or respiratory chain defects presenting as hypoglycemia. Mitochondrial disorders can also present on day 1 with hypoglycemia. You generally suspect when you do not have risk factors for hypoglycemia, especially a term baby presenting with hypoglycemia and encephalopathy.
Sure. Thank you so much. I think we have enough time for questions, or there is a time left, Prashant sir?
No. Please clear all the questions.
Yeah. So then question.
I'm requesting if time allows to continue the slides of Dr. Abhishek as well. But first clear off all the questions, and then if time permits, then we'll see.
Sure. The next question for you, Abhishek, as well. Dr. APURVA, I know you have been patiently waiting. There are a few questions for you.
I'm totally happy. Everybody understood the whole topic, so I'm extremely happy with no questions.
No, there are questions for you, so they're coming. So, Abhishek, where is DOPA PET scan done? I think in Bangalore, as you are practicing in Bangalore. Do you know any places? I mean, one of the candidates have put a question. Which place he has not done? Where do you usually do?
Fortunately, till now, in the last 2.5 years, I have not got any such case where we require PET scan. But I think any center which does PET scan does DOPA PET scan as well. I think PET scan is done at Manipal, and even Bangalore Medical College used to do earlier days. Now I'm not sure really. I think Shiv, you are the better person to answer.
No, it's done in any nuclear medicine setup. Yeah, there. I mean, if you go to any diagnostic centers with nuclear medicine department, there they would usually do. So I think it's quite.
Manipal must be doing, I believe that.
Yeah. The next question for you, Abhishek. Any role of feeds fortified with sugar in managing hypoglycemia?
Can you please repeat the question?
Any role of fortified feeds with sugar in managing hypoglycemia? I mean, how much?
Fortified feeds while managing hypoglycemia.
Yeah.
Additional formula milk to the feeds as well. But unfortunately, you do not know how much to add and what will be the change in osmolality or whether it will cause vomiting or not. When we have safer dextrose fluids available, I think fortified feeds, we need more evidence. You can still better continue with unfortified milk itself.
Okay. Can we add sugar? I mean, one of the candidates have asked, it's also an interesting question, is can we add 25% dextrose?
So how much to add, what's the change in osmolality will be the big question.
Yeah.
How much to add and what changes in osmolality it causes is not known. I think when we have safer alternatives, better to use safer alternatives rather than using fortified ones is what I feel.
Okay. Can we add 25% dextrose to milk, in treating hypoglycemic kids? I'm sure it's no, but I want to know from you. Yeah.
I would again stand as no for that, because we're not sure about the osmolality with that.
All right. Okay. So another question is, if a baby is having continuous blood glucose consistently, sorry, this is for Dr. Apu, it was that. And for hypoglycemia, how do you prepare dextrose solution is one of the candidates have asked, like for preparing 20% or 25%. Did your presentations show any formula on preparing dextrose concentration? I'm sure you talked about it, but was there a formula presenting how to prepare glucose? 20 or 25% dextrose or any 15% dextrose? Hello? Hello? Hello?
Sir, we can hear you, sir. I can hear you at least.
Abhishek, have you lost us?
No, everybody can hear. You're just muted. You are asking question, no? That's why.
Okay.
Go ahead. This question is for Dr. Apur.
No, it's for Abhishek. How do you...
Okay, yeah.
Okay. Meanwhile,
can you please repeat the question, Shiv?
How do you prepare dextrose solution? One of the candidates have asked is, how do you prepare dextrose solution higher than 10%, like 15, 20 or 25%? Is there a simple formula where they can use, or do you use an app or something like that?
At present in our unit, we make use of an app by which we calculate dextrose, and we usually cross-check before administering. But there are several glucose calculators which are available. So I think one of the slides had it. So this is one of the ways which we use to traditionally prepare glucose infusion in our postgraduate. So let's assume you have a 2 kg baby on 100 ml per kg per day of IV fluids who needs 6 mg per kg per minute of glucose. So 6 hourly, the fluid requirement will be 100 into 2, that is 200. 6 hourly, it will come out to be 50 ml. So you need to give 6 mg per kg per minute, that is 6 into 2 into 60 into 6 hours. You need to deliver a glucose of 4,320 milligram of glucose. Let X ml, let's assume X ml be 10% dextrose, Y ml be 5% dextrose, need to make IV solution for 6 hours. We all know 1 ml 10D contains 100 mg, while 1 ml 5D contains 50 mg, and 1 ml 25D would contain 250 mg of glucose. So the first equation will be X plus Y is equal to total fluid volume in 6 hours. X plus Y is 50. Equation 2 will be 100X 50Y is equal to glucose to be delivered in 6 hours, 4,320. So to solve this, you generally multiply by 100 And then I think everybody would know this mathematical way to handle X and Y easily. It comes out to be 10D comes out to be 36 ml, Y comes out to be 13 ml. I think it's quite complicated for the nurses. We generally make use of this dextrose app currently in our unit. I think we also have EMR in our units, which actually can calculate dextrose for us. So I think currently we are using this dextrose calc, GR and calories calculator in the NICU.
Okay. So the next question again is oral glucogel available in India?
Yeah, it's available in India.
Okay. And any prerequisites prior to doing the PET scan? I mean, like if you have started on diazoxide or something, do we need to stop those medications?
Diazoxide should not affect PET scan results.
Okay.
I am not aware of fully about PET scan preparation.
All right. So how much GIR can we give through umbilical lines? Dr. Apurva, this question is for you. How much of maximum GIR concentration we can give via umbilical line?
See, as far as maximum go, I mean, usually hyperglycemia doesn't deal with maximum GIR. We deal with more minimum GIR. I would be extremely skeptical anytime you have crossed a dextrose of 20. So I would not infuse anything more than D20 through my lines. And that is where I find the questions on icing sugar and other things with the feed, because that is the only, like sometimes if you don't have central access, that is when once you have crossed D20, that's when I would consider starting using hydrocortisone and other things. As far as minimum, there is no minimum concentration per se. So for hyperglycemia, I would think about low GIRs, and I would not go beyond 5. And this is especially true in the preterms, and especially when you have any baby less than 600 grams, the amount of fluid that you can give is extremely limited. And you cannot go below. Sometimes I've seen certain babies, the sugar is just so high that you are coming down to a GIR of 2, 2.5, 3. That would not be acceptable. Their glucose, the brain would need some amount of GIR continuously for this glucose maintenance. Because just because glucose is in the blood does not mean the glucose is utilized by every organ. So I would not focus on high GIR, but more so low GIR for hyperglycemia patients.
Okay. So the next question is there a classification for hyperglycemia? You have spoken about the outcomes in babies based on mild, moderate, and severe.
Right.
From one of your journals. How do we classify as like mild, moderate, and severe? Are there any cutoff values for that?
There are no cutoff values. Basically, the different studies I have went, they chose a different point. Like one of the studies just chose arbitrary more than 180, less than 180. I don't know if there was some amount of data mining that made them determine that, okay, below this level, we are seeing more effect versus less effect. Majority of the time, severe hypoglycemia is seen in 250 above, sometimes 300 above.
In those studies, sorry to interrupt, in those studies, what did they use? I mean, at least
250 plus, 250 plus, 250 plus.
All right. So the next is, in case of a baby with hyperglycemia, do we need to reduce the amino acid infusion also along with reduction in GIR?
I would not reduce amino acid infusion, as one of the reason is that the babies, if they're not getting sufficient amino acids, they end up doing proteolysis. They start to break their own protein down, which then subsequently lead to suppression of incomplete suppression of hepatic glucose production and leads to hyperglycemia. So if anything, I would consider giving these babies amino acids, adequate for their age, adequate for their age of life, as well as adequate for their gestational age, as an alternative source to keep the sugar down. So I would not reduce, I would actually make it optimal.
Okay. So the next question for you as well is there an entity in newborns called insulin-resistant hyperglycemia?
Insulin-resistant hyperglycemia, yeah, it is like, there is like, basically, if you look at in a very sort of a crude physiological manner, all the hyperglycemia are insulin resistance. Because the problem is not like they have some kind of a receptor deficiency or something. It's just that their cells are so immature and the receptors are immature at a level that the insulin does not function in the same manner. One of the study I told you that they followed up these preterm babies. They got an insulin level at birth, and then they followed up with insulin level as they developed hyperglycemia. At the time of birth, the insulin level in euglycemic as well as hyperglycemic babies was comparable. But then the babies who ended up developing hyperglycemia, their response to insulin was not adequate.
Okay, sure. Thank you. And the next question is, sorry, I'm just, because there are a lot of questions, so I'm just, I lost some of them. And yeah, what are the IV fluids for neonates for different level of hyperglycemias? Like, what all you use, 5%, saline?
What we use, at least in our facility here, is we do not use any pre-mixed formulas. We basically, what we do is we take a D10, D5, D7.5, depending on the sugar value and where you're trying to achieve, and then add the amount of sodium and potassium based on the gestational age and other comorbidities. We usually tend to use a little bit higher sodium in HIE babies here. We tend to avoid potassium in case of there is urine output, like the baby's extreme septic with AKI and other features. We kind of make it as we go along, but the base is dependent on the level of sugar. And again, I would want you to use the current, the talk more in terms of recognition. I don't think we need to be trigger happy with managing hyperglycemia, but recognition and involvement of sepsis and HIE are more important. If you have consistent hyperglycemia, try to come down on your GIR by 1 or 2. You can go from D10 to D7.5 and just keep checking sugar whenever you make a change.
Okay. Is there any glucose cutoff where there is a risk of high risk of IVH, like 300, 250, at which IVH increases?
Honestly, I have not come across a study where they would compare glucose level with IVH. There are studies that show that IVH was more commonly seen in the babies who had hyperglycemia, but there was no sort of statistical analysis that was done that, okay, above so-and-so is the cutoff for IVH per se. Okay. So I would just try to keep the sugar level steady and preferably below 200. That's where I would try to shoot for.
Below 200. All right. So when you reduce the amino acid infusions, I mean, we don't reduce the amino acid infusion in babies who are hyperglycemia and just reduce the GIR. Do we need to worry about the calorie nitrogen, protein nitrogen ratio?
Correct. See, that is the problem with that is the high BUN is also not just reflective of the nitrogen balance, but sometime in preterm babies about utilization of nitrogen also. So sometime preterm babies, if their utilization is good, their BUN will be high. So trying to interpret just high BUN without creatinine is a little difficult. What I would do is you go with the best possible management for that baby. I would not stop amino acid in any case, but if your BUN keeps going up, I would make it, if you are worried about it, maybe come down to 1. Don't go below 1, but at least 1 gram amino acid per kilo is okay. But try to shoot for 2 or 3 depending on the age.
Sure. Thank you so much for answering all the questions. One of the nuggets shared by, I'm sure it's Gautam Suresh sir. He did ask Abhishek about whether you spoke about James Bond method of calculating GIR. Do you know anything about that, Abhishek? He did tell to share if it's not being shared. It's ml per kg per day of you must be knowing. Do you, Dr. Apur? James Bond method of calculating the GIR.
No, please enlighten me. I was just
It's not me. It's
all serious listeners and serious.
So he has asked to share this. If you can share, it's ml per kg per day of IV fluids multiplies percentage of dextrose multiplies 0.007. That's equal to glucose infusion rate. You get it. So he's also shared an article which we'll be sharing in the group to all the NNF candidates. I think we are done with the questions. Thank you for answering all those questions, really clearly. I hope it was helpful. Over to you, Prashant sir.
Yeah, I'm sure today's session it's perfectly balanced, starting with hypoglycemia to hyperglycemia and then euglycemia. So, and thank you. Special all the participants, because of the issues which we saw today in the chat box, all unrelevant people had logged in. So we have to become more strict, so that we have created a waiting room now. Anybody who would like to participate in henceforth thing, first they'll be scrutinized by us, and then we will take them in. So I would like to thank fantastic speaker, young dynamic speakers, Dr. APURVA, Dr. ABHISHEK, and Dr. Shiv for moderating the session. So I request my President, Dr. Kotreshi, sir.
Very nice organization skills. You and both moderators have done a wonderful job. Especially thanks for ABHISHEK and APURVA going a very good importance of what is the blood glucose level in the newborn babies. Whether it is hypoglycemia or hyperglycemia. It takes both IMs. It should be ideally normal. Then only baby can be healthy and we can give the good message to the society. Nice to all of you. Thank you very much.
Yeah, I'd like to introduce Dr. Kishore sir. Kishore sir.
Hi, Prashant.
Yes, sir.
Sorry. Hi, Prashant. Thanks very much for definitely conducting today compared to yesterday. There was an outrage in Zoom and everything fell apart, which clearly is a problem sometimes we face with the technicalities. But hopefully, ABHISHEK and APURVA didn't get disheartened, because young dynamic neonatologists, we wanted to listen, and definitely it's very disappointing to postpone their lecture for 24 hours, but they've done justice, and well done, APURVA and ABHISHEK. We want to hear more of you in the near future. Thank you.
Yeah. So all the congratulations has been conveyed by Dr. Gautam Suresh and all the people who have been participating, our seniors and our colleagues. So thank you very much. We'll close the session. Have a good Monday evening. And we promise you that we work more stronger and more harder to make sure that the Zoom is safe. So, and we're going to scrutinize each and every participant from henceforth. So I request all the participants to please put your proper name so that it's easy for us to allow you inside the session. Let the knowledge flow and let all irrelevant things move away from us. The focus is that, the focus of Neo Masterclass is that, and NNF Karnataka chapter is that. Thank you very much for joining all the participants. Thank you. Thank you. Have a great evening. Bye.
Thank you, sir.